2021. It is the last Monday of every month. The topics covered so far were Langerhans cell histiocytosis, Waldenstrom management, plasma cell disorders, amyloidosis, and graft versus host disease. We would like to thank the sponsors, Janssen and Hikma, for their unrestricted support of this series. And today's session would cover challenges in myelodysplastic syndrome. The objectives would be personalized MDS management, clinical challenges in with a focus in bone marrow transplantation, and some of the diagnostic challenges, especially when it comes to very difficult to read NGS report, and then we would have the question and answer. We have a distinguished faculty today to cover. The agenda would be Professor Garcia will be talking about personalized management in MDS. We would have maybe 1 or 2 questions after his session. And then Dr. Syed Ahmed will be talking about the clinical challenges, again, a focus on transplantation. And then Dr. Abdullah Alsuwaidan will be talking about the diagnostic challenges and how we can interpret the NGS Myeloid report. And then we would have the questions and answers. The seminar would be fully recorded and would be available. So with that, it is my honor to introduce Professor Garcia. I guess it's Garcia Manero. It is a very long CV, and just to give you time for your presentation, I'll make it really short. He is currently a professor in the Department of Leukemia at the MD Anderson University of Texas. He's also the chief section myelodysplastic syndromes, and he's a deputy chair of the translational research, and again at the same center at the MD Anderson. This is very important for the residents who are joining us now. He's the fellowship program director at the Department of Leukemia at the MD Anderson. He's well published, many grants. He started in 1990 with a research award as a student, and his most recent research award was in 2018 as a full faculty achievement award. It is my honor to introduce you, and the mic is yours, Professor Garcia.
Thank you very much. This is a great honor. Let me share my screen. Give me 1 second. Okay. Perfect. Thank you. Can you see the screen?
Yes, we can.
So it's a great honor to be part of this symposium. I've been in many of the MENA meetings over the years, and I have a lot of great friends in many of your countries. As you know, I'm from Spain, so I feel very close to all of you. And I'm happy in the next 20-25 minutes to talk about what's happening in MDS. There is a lot of progress, and I'm going to try to do my best to discuss this. So let's start first with a very simple updated algorithm of how we treat patients with MDS in 2021. We divide patients into low risk and high risk disease. Today, we use the IPSS-R classification, but you could still use IPSS. As it will be discussed later, and you will see during my talk, the genomic annotation is very, very important as well as we think about treatment and prognosis of our patients. And then for those patients that are lower risk, there are a number of interventions that I'm going to briefly discuss, like iron chelation. I'm going to briefly discuss luspatercept, the role of the hypomethylating agents. I'm going to show you some new data for del(5q) MDS from the ASH meeting that was very interesting. When we go to higher risk disease, what you see in this graph, this is from a review paper in American Journal of Hematology a few months ago, things that are starting to happen at least here in Houston and many other centers in North America, are that the threshold for transplantation is increasing. We're now transplant up to age 75, of course, depending on donor and how the patient looks like. And there is also debate of whether we should give chemotherapy or hypomethylating agent-based therapy. I will be discussing this through the talk. Another very important slide is this one. I think this is critical because this is how I think about this disease, MDS. As you see here on the left, there is this prodrome of ICUS chip. This is the clonal hematopoiesis, cytopenia of unknown significance. I'm not going to discuss this. These are prodromic phases before the MDS. And then those patients with low risk and high risk. And then we divide them into those patients that are naive, particularly naive prior to hypomethylating agent-based therapy, and then those patients with this so-called hypomethylating agent failure. So this is very critical to understand, because when I think about these patients, I divide them into these 4 different groups: low risk untreated, low risk HMA failure, high risk untreated, high risk HMA failure. So let's start with some of the data that was presented between 2000 and 2021. The first one, very quickly, is this issue of iron chelation. I think in your countries, you are very familiar and are experts on this topic, because there's quite a bit of, I understand, hemoglobin disorders like thalassemia. But in MDS, the role of iron chelation was not that clear. And then this paper that we published in the Annals of Internal Medicine a few months ago showed from the randomized clinical trial showed that actually iron chelation of patients with MDS improved the outcome of these patients, particularly in affecting other comorbidities. So this is important data that finally prove a role for iron chelation in our patients with low risk disease. The other important thing that was really important, and it was presented at ASH a couple of years ago, and then the paper in the New England Journal of Medicine came back also this year in 2020, was the development of a drug for patients with low-risk MDS that had failed an erythropoietin stimulating agent. This is a drug known as luspatercept. Again, this is for patients with refractory with ring sideroblasts that had failed an ESA. And in this randomized study, we showed that this TGF-beta modulator, luspatercept, was able to improve the rate of transfusion independency in patients that were anemic, transfusion dependent, compared to placebo. So this actually was the first drug approved in the United States for myelodysplastic syndrome in almost 15 years. So this was a very important issue. Now, of course, right now, the role of this drug is a second line in low-risk MDS, basically for anemia. Data at ASH this year that we felt it was very important, it was from the Spanish MDS group by Dr. Lopez Cadenas. And I think this is a very interesting concept. I don't know what the practice in Saudi is, but here in the United States, we do not use lenalidomide for patients with del(5q) MDS unless they are already transfusion dependent. So this study from the Spanish MDS group, this is a very important, very powerful group, performed a randomized trial called the Cibmtr trial. You see the schema here, where they gave a little bit lower dose of the lenalidomide, 5 milligrams, for patients with del(5q) minus MDS, but these patients were not transfusion dependent as of yet. And then they randomized between early lenalidomide versus no lenalidomide, with the lenalidomide being used later on when the patient became transfusion dependent. Now, this is a phase 3, but slow accruing trial, and this was an interim analysis, but the data is very interesting. So basically, what these investigators show was that if you start the lenalidomide early, although it's a lower dose, 5 milligrams, the time to transfusion dependency was significantly prolonged. Actually, it was from like 2.8 years to 6.3 years. This is quite dramatic. These investigators also showed, of course, that there was improvement in cytogenetic responses and so forth. So this is now starting to change our thought process, because perhaps instead of waiting for these patients to become transfusion dependent, one could consider a lower dose of a drug like lenalidomide for this del(5q) minus group of patients. The other issue that is very important, particularly in North America, is the role of the hypomethylating agents, either azacitidine or decitabine, for patients with low-risk disease. And this is an update from a study performed at MD Anderson. This was presented by Dr. Sasaki from our group that shows actually that in patients with low-risk disease, early introduction of azacitidine at a lower doses, perhaps we can discuss this later, is associated with an improvement in outcome compared to historical data at MD Anderson. And then finally, to finish the part on the low-risk disease, just to mention the development of a new compound that is progressing very quickly through phase 2, phase 3 trials. This is a drug known as imetelstat, a drug that Dr. Teferi at the Mayo Clinic had developed for patients with myelofibrosis that is now showing significant activity in the same group of patients where luspatercept has activity. So again, this drug interferes with the telomere function of these cells. The data is actually only on 38 patients, so it's limited. We have to take that with some caution. But these investigators are showing a very significant improvement in transfusion independence, as you can see here, around 42%. So this could be another drug that could help our patients with anemia after failing an ESA. So we need to see and wait what happens with the rest of the results from this new compound. But this is basically for your information. Now we move to higher risk disease. Of course, here the most important drug that we have had now close to at MD Anderson 20 years is azacitidine. This is a hypomethylating agent. This is from the famous study of Dr. Fenot from France. This is the ASA-001 trial that led to the approval of this drug that showed an improvement in survival. Of course, this is nice, but this is not the cure. So for years, we've been thinking about how to improve the outcomes of our patients with myelodysplastic syndrome high risk, basically around the concept of a doublet built on a hypomethylating agent such as azacitidine. So for years, we actually failed to achieve this. And now, all of a sudden, we are seeing a lot of clinical trials with very exciting data from doublets that I think at some point are going to really change the natural history of high-risk disease. There is no particular order for the data I'm going to show. This is how I put the slides. But some of these drugs may be approved at some point in the United States, at least for our patients. So the first presentation at ASH this year, in 2020, we're already in 21, obviously, was actually from a randomized study of the combination of azacitidine with pevonidostat. Pevonidostat is a drug that interferes with methylation. This is a process for protein modification in the cell. And this actually is a study that has been presented multiple times at ASH and at EHA, but the data keeps maturing and improving. And here, what Dr. Sequeres, who is now in Miami, showed was at this group of 67 patients with higher risk MDS. This is the scheme of the study. It's azacitidine with or without pevonidostat. And again, this is not the full totality of the trial, but what these investigators are showing is that the event-free survival was significantly better for those patients receiving ASA plus pevo versus azacitidine alone. And there was a trend to improve in overall survival as well with this doublet. This is very encouraging data, particularly because pevonidostat appears to be a very safe compound that does not add significant myelotoxicity to our patients. There is an expectation that in 2021, we may see the final results of a randomized study called Panther that we hope will show a definitive data in terms of this doublet. Also of importance is that we see that the response rate with this ASA pevonidostat was higher than what you will see with azacitidine alone. As you see here, a response rate close to 80% with a complete remission rate of around 52%. So this is very nice data with this doublet. The second doublet of great interest is combining azacitidine with immune checkpoint inhibitor known as MBG453 that now we call sabatolimab. So this is a drug that targets TIM3. This is a molecule similar to CTLA4, PD1, PDL2, etc. This is a multi-center trial. And what is interesting about the TIM3 is that it's also present in the leukemia stem cells. So this drug, sabatolimab, may have an effect not only on the immune component of this disease, but also perhaps directly into the leukemia stem cells, as you can see in that cartoon. And then this study is a little bit less mature than the data that I showed you with pevonidostat. But again, we're starting to see responses with this combination of an HMA, in this case, the cytamine with MBG of around 26% for an overall response of around 60% or so, without actually a lot of the immune toxicity that we have seen with nivo and ipilimumab in this group of patients. The third doublet that we are very excited, and of course you are very familiar with this, is the study of azacitidine with venetoclax. Of course, venetoclax is the BCL2 inhibitor that is approved in combination with azacitidine for elderly patients with acute myelogenous leukemia. And then we have developed a similar study, a phase 1, phase 2 trial, trying to see the safety and activity of this compound for patients with higher risk myelodysplastic syndrome. This has taken quite a bit of time because there is, of course, some degree of myelosuppression and potential toxicity with this doublet. So we look at different doses of the venetoclax and the azacitidine. But the data that has been now updated a couple of times at ASH, it keeps maturing in a very nice way. So the response rate complete was around 40% for an overall response rate of around 80%. And then doctors and people are concerned about myelotoxicity of this program, but we see actually that the rate of transfusion independence is around 65 to 77% for red cells or platelets red cells alone. So we actually see recovery of peripheral counts in this group of patients. So this is really exciting data. And also what is important here is that with a median time of around follow-up of around 17 months, we don't see a median survival yet on these patients. So it looks like this doublet actually not only gives you a response, it could be actually improving survival. There is also a very important phase 3 trial, clinical trial called Verona that is now open that will hopefully prove the point that the combination of AZA plus venetoclax may be superior to azacitidine alone. The other drug that is causing a lot of interest, and there's rumor that this drug could be approved in 1 or 2 years. So all these compounds are not in the far distance; they are very close. Is this drug known as Macrolime? So what is Macrolime? Macrolime is an antibody that binds to CD47. This is a very important feature of macrophage activity. So basically, what it does, it activates these macrophages. So people refer to this as an activator of macrophage function, kind of like an immune checkpoint inhibitor, for macrophages. And in early data by Dr. Salman in Moffitt and people actually in United Kingdom, we're seeing actually a response rate that is close to 90% actually over in combination with azacitidine as frontline MDS, and also significant activity in acute myelogenous leukemia. So this is actually a very interesting concept, and this drug now is also engaged in a major phase 3 randomized trial of AZA without magrolimab. Moving to more specific personalized type of therapies, I'm going to briefly discuss something that is now very confusing to us, that is a compound known as APR246. As you know, one of the major problems that we have in myelodysplastic syndrome is this group of patients with P53 mutations. APR is a drug that binds to the P53 protein and kind of modulates its function. And there are 2 studies that were just published in the JCO, one by the European group and one by the French group by Dr. Clouzot from Marseille, that showed that the combination of APR plus azacitidine actually was associated with a very high response rate in P53 mutated high-risk myelodysplastic syndrome in the front line. Why I said that this is confusing is that we just heard, we have not seen the data, the results of a randomized study of AZA plus APR that unfortunately is not giving us the same type of signal that we saw on the original phase 1, phase 2. So we need more data here. Now, later we're going to hear about this issue of the genomic annotation. This is really crucial in myelodysplastic syndrome. I've heard some people saying, no, this is not as important as in AML. I totally disagree with this. So we'll hear that in a minute, but let me just walk you through this very quickly. So around 10 to 15% of patients have an IDH2 mutations, and they actually do very well with the combination of a hypomethylating agent with IDH2 inhibitor. Around 5 to 10 with the IDH1, the same concept. Those studies actually are ongoing in the United States, but there is, at least in this country, nothing that will stop you from using that targeted type of approach. Around 15 to 20% of patients will acquire FLT3 mutation at the time of failure. and therefore they could be candidates for FLT3 inhibitory type of approach. We discussed BCL2, we discussed CD47, we already talked about P53. I forgot to mention actually that the Macrolime, the drug that actually targets the macrophage, has significant activity in this group of patients with P53 mutated disease. And then NPM1 is a curiosity, but around 1 to 2% of the patients with MDS have this mutation, and they do extremely well, meaning cures, if you treat them with high-dose chemotherapy, perhaps sometimes followed by a stem cell transplant. So if you do the math, actually, you're talking around 40% of the patients that may benefit from some type of targeted, personalized intervention. So please keep that in mind. This is the schema of how we approach our patients at MD Anderson. This is an important thing to follow. Patient comes generally for confirmation of diagnosis. In our center, we have discussed and reported around a 15 to 20% discrepancy rate from one center to the other. So it's critical to confirm the diagnosis. Some of these patients now have this clonal hematopoiesis, CCUS. At MD Anderson now, we have a clinic that deals with these patients specifically. If they have confirmed diagnosis of MDS, in our opinion, it's mandatory to perform this genetic screening. As I mentioned earlier, IDH1, IDH2, FLT3, NPM1, TP53. So this may be very important. And if they are agnostic for the mutations, then you're going to divide them into low risk, high risk, and then you're going to divide them into HMA failure. One thing that I don't have time to discuss in 20-25 minutes is the role of transplantation, but this is very fundamental because now we are becoming really good at inducing remissions in these patients with high risk disease. And therefore, this topic of maintenance therapy and how to integrate total therapy for our patients is becoming crucial, but this is a little bit beyond the time that I have. And then to conclude my talk, I want to spend a couple of minutes into this very important topic of some drugs that are coming, that is oral hypomethylating agents. There are two compounds, at least in the United States. The first one is this oral decitabine. This is actually a combination of oral decitabine with a cytidine deaminase inhibitor known as cedazuridine. The drug was approved this summer in the United States. It's called ASTX727. There is a similar compound that combines azacitidine with this cedazuridine in development. And then, of course, you know that also this year we saw the approval of oral azacitidine approved for AML as a maintenance type of approach. I'm going to go very quickly through this. First, to show you, this is data published in Blood, presented at ASH a couple of times. Again, the drug just approved a few months ago. This is the CERTAIN clinical trial looking at oral decitabine. And here what we did basically was to compare the pharmacokinetic profile of oral versus IV decitabine. So that was actually the approval. And what we found is that these drugs pharmacologically are virtually identical, 99%. They are very well tolerated. They are very active, actually, single agent complete response rate of around 22%. This was the update at ASH this year, and a nice survival. So we see that in the United States, we're going to, particularly now with the time of COVID, etc., there's going to be perhaps some potential role for these oral HMAs. Now, I want to talk 2 seconds about the oral azacitidine because there is some confusion, at least in the United States, about the role of this drug approved for AML in MDS. So this is drug that I developed actually at MD Anderson for many years. This CC486, this oral azacitidine, has a significantly lower PK profile than the regular azacitidine, as you see in the slide here. And we perform a phase 3 trial that's actually coming out in the JCO anytime for patients with lower risk disease. The drug has not been studied in high risk disease. We found, this is the schema of the study, we found actually that the compound was very effective in improving red cells and actually platelets, but unfortunately, we saw no improvement in overall survival because there was a little bit of early death, early toxicity in these patients with lower risk disease. So I don't think that, even if I think that CC486 is my daughter, that this is not ready yet for use in patients with myelodysplastic syndrome. So you need to be aware of these differences. So in conclusion, I think we're going through a transformation in MDS, and this will translate into your countries pretty soon. So this is not something that is going to happen in 10 years. We're seeing actually the development of these oral hypomethylating agents. This is going to make the life of our patients much easier. So this is really important. And of course, there will be multiple potential combinations. For instance, imagine oral hypomethylating agent with ABT 919, IDH inhibitors, FLT3 inhibitors, and it's for sure going to facilitate therapy after transplantation. I think Also, the data that we saw at ASH this year is really interesting because we're starting to see that perhaps early intervention in MDS, and this was shown by the Spanish group for the del(5q) with the lenalidomide, may be very beneficial for our patients. We've been studying that with the hypomethylating agents in low-risk disease as well. So perhaps we need to be a little bit more aggressive with these non-toxic modalities for our patients. And then what I think is very exciting is that using a doublet of azacitidine plus, we're starting to see very important doublets with pevonidostat, magro, venetoclax, savolitinib, APR, that hopefully will give us a combination with azacitidine that does better than what we get right now with a single agent azacitidine, but we have big needs. I didn't have time to discuss, but for low risk and high risk HMA failure, they're all very investigational. They are not major studies, so I didn't put those slides here. And for sure, we need to get better at incorporating a stem cell transplant in our patients. And with that, I would like to conclude my talk. Again, this is a great honor. I'm happy to take any questions. I'm extremely grateful for this opportunity. And I'm very happy that Dr. Murtadha was saying that I'm the director of the fellowship. We love to have, actually, we have always fellows from Saudi and many other countries. Please contact me directly. This is my email address. We would love to keep working with you and supporting you in any way we can. And again, thank you very much.
Thank you, Dr. Manero. Very nice, extremely up-to-date presentation. So as we planned, we will take only 2 questions and then go to the other speakers. So the first question is about the biology of MDS. And the question is, do all AML, are all AMLs preceded by MDS? And do all MDS, if left untreated, progress to AML?
No, this is a phenomenal question. This is my life. I'm very grateful to whoever asked this question. Thank you very much. So there are 2 types of AML. One is the AML that we cure, acute promyelocytic leukemia, core binding factor. Those AMLs, NPM1 mutated, they are evolving from progenitor cells in the bone marrow. Those are the ones that we cure. Then you have the other type of AML that evolves from a more primitive stem cell, that is the MDS, that's the question. These are the patients that don't do that well. So that's very important. The second question is very important for me. So if you allow me 10 seconds. My professor in Philadelphia was a very famous hematologist, Dr. Erslev. He discovered erythropoietin. He was one of the most famous hematologists of his time. He died, unfortunately, many years ago. When I was a fellow student, he told me, Guillermo, don't worry about this MDS. This is pre-leukemia. Everybody transforms to AML, and then you deal with it. Okay, that was Dr. Erslev. But my first paper on MDS, 20 years later, when I became faculty, showed me actually the reverse, that most patients with MDS unfortunately die from MDS, around 80%. So actually transformation happens maybe only in 20–25% of the patients. Most people will suffer from the MDS itself. And that's why it's so important that we think about directed interventions for our patients with MDS. But historically, this is a very important question for me. Thank you very much.
Thank you very much. The other question is, in high-risk MDS, what do you, outside clinical trials, what do you do with those who progress after hypomethylating agents and those who are not transplant eligible?
Very good. Okay, so this is very critical. I'm going to explain to you in 2 minutes, but I think it will make sense. In my opinion, it is very, very important to repeat the genomic panel at the time of relapse or no response in these patients with high-risk disease. We documented that these mutations change in around 20–30% of the patients. So for instance, the patient was negative for IDH2, now is IDH2 positive, or negative for FLT3 and so forth. So you may find that by repeating the genomic testing, you may find a targeted approach, number 1. Second, very important, a subset of patients with high-risk MDS HMA failure, they actually are diploid. The cytogenetics don't change. Those patients actually do well with low-dose nucleoside analog type of approach. So for instance, things that we do at MD Anderson right now will be low-dose cladribine with low-dose cytarabine. We have a clinical trial with low doses of Bixios, the CPX351, that's another alternative, maybe low-dose fludarabine, some type of low-dose nucleoside analog with a little bit of cytarabine, perhaps some venetoclax, that at a lower dose, but only in the patients that are diploid. If you use this kind of treatments in non-diploid patients, they will get sick and they will not do very well. So if you are able to select because of the mutations, because of the cytogenetics, you may actually have some therapeutic intervention. For the others, this is very complicated, and looking for a clinical trial is probably your best approach. And then finally, for those patients with lower risk HMA failure, we see a lot of this in the United States because we use a lot of hypomethylating agent. The best option is to take them to transplantation. If they are still in low risk disease, the cure rate actually is quite significant. But of course, unfortunately, many of our patients are older and may not be candidates for transplant. So in summary, look for cytogenetic, look for mutation, and see if there is an angle for therapy outside the clinical trial.
Thank you again. Thank you very much. Now we proceed. You can still write, I mean, for the audience, you can still write your questions. Please put them in the Q&A, and we will try to answer them at the end of the session. Now we proceed to the second speaker. It is my pleasure again to present a colleague, Dr. Syed Osman Ahmed, who is, we've known now for a number of years, well known in the region. He's currently a consultant at adult hematologist and BMT at King Faisal, Riyadh. He is a lead in the CAR-T cell development program. He's a member of the Cancer and Therapeutics Subcommittee at the center, and he's also a member of the Cellular Therapy Committee. His talk today will be addressing some of the challenges in transplantation when it comes to MDS. Dr. Syed Osman, the mic is yours.
Right, thank you very much. I'm just going to share my screen, if I may.
We can see it. Just put it on display. Oh, can you share again?
Right. Sorry. Sorry, can you see my screen? Or?
Yes, we can.
We can. Can you?
Yes.
Okay, great. Okay, thanks. So now, okay. So I'm going to give a brief overview of the clinical trials of MDS as pertains to transplantation over hopefully the next 15 minutes or so. So just a brief overview and a reminder that hematopoiesis is an amazing process, and we're endowed with amazing machinery in our bone marrows that allows us to produce 10 trillion cells each day. And it would be great to hear about from Dr. Alsuwaidan about some of the molecular things that can go wrong. And our bone marrows have to produce large quantities of cells with good quality. So when that fails, we've heard about what Dr. Garcia said, but perhaps the truly curative treatment for MDS is a bone marrow transplant. And perhaps it's underutilized. And there are a number of challenges that we face with these patients. And it's always a challenge to decide who is the right patient to transplant and when should they be referred to a transplant center. Just an overview now, MDS is one of the most frequent indications for allogeneic transplantations is Cibmtr data from the US. And as you can see over here, in terms of allogeneic transplants, after AML, it's MDS/MPN. And the numbers of transplants for MDS are increasing. So that's AML. The green line is ALL, and as you can see, of the indications for which the numbers of allotransplants are increasing, then MDS is certainly one of them. And that's probably related to our being able to have access to more donors, reduced TRM, and better management of complications and prevention of them. As for survival of patients undergoing transplantation for MDS, this is somewhat reassuring. So early MDS, the outcomes for survival are better than they are for advanced disease, both in the HLA identical setting and in the matched unrelated donor setting. Have survival outcomes been improving over the last few years? They have been, as you can see from the curve over here. These are significant with large numbers. So the median survival has been improving over these periods of 5 years each. So it looks like the survival is getting better. And the transplant, as we said, the numbers of allogeneic transplants that are being done have also been increasing. So we think that we will be seeing more patients getting transplants for MDS. And there's another factor that's going to come into play over here, especially in our populations. Especially in things like better detection, better referral, and also the secondary MDS, the therapy-related MDS. As we treat solid tumors better, we're probably likely to see more patients with therapy-related MDS and secondary MDS. So that is something that I think transplant centers should prepare for. This is a snapshot of what it is in the region. So this was an analysis done by the Ebmt and the Ebmt and the African AFBMT groups as to MDS in these respective regions. So as you can see over here, obviously the numbers for MDS MPN are nowhere near as high as they are worldwide. Only 58, but that number will be increasing. That's partly because of the low numbers of transplant centers and access to transplant in the region. On the left is the analysis from Saudi Arabia of transplant activity over the last few decades. So that 5% of allogeneic transplants were done for MDS. On the right was cumulative activity data for the Eastern Mediterranean region. So it is the fourth most frequent indication for allogeneic transplantation over that time period, which was a 24-year time period. But again, we would expect the numbers to be increasing. So in terms of registry data, what does it look like? So this was a study done by Z. Lim, who was at King's some years ago, looking at allogeneic transplantation for patients 50 years or older with MDS or secondary AML. They looked at about over 1,000 patients over the age of 50. Most of them had HLA identical sibling transplants. Now the 4-year overall survival was 31%, which is acceptable considering that this is a curative therapy and the other ones who don't get a transplant aren't actually getting curative therapy. Certainly up until this point, but obviously the field is evolving. Those who had a VIC transplant and advanced disease had an increased risk of relapse, and advanced disease and a MUD transplantation were associated in that cohort with increased NRM. I'm going to come to the issue of conditioning in a few more slides. This was a comparison of the Ebmt and Cibmtr data. And as you can see, the overall survival for the Ebmt data set was 34% in the 50 to 60-year-olds. And as patients get older, the survival decreases. In the Cibmtr data set, the same seems to be the case. The overall survival is about 45%. There seems to be a dip in this age bracket. But overall, you are able to potentially cure a significant proportion of these patients with MDS. So the questions that arise are, who should undergo a transplant or be referred for transplantation? What is the best time? What is the optimal conditioning regimen? What is the optimal type of transplant? And who is the best donor? Obviously, the goals of allogeneic transplantation, when we approach a patient, is obviously we're trying with our conditioning regimen to immunosuppress the patient, to cytoreduce, to produce space, and hopefully to produce a graft versus leukemia effect. Now, is there a graft versus leukemia effect in MDS? Now, there was a Ebmt megafile analysis that was done some years ago by Stern et al., trying to find those patients or those transplants and those diseases where there may be a GVL effect, and that was correlated by the incidence of GVHD. So they looked at 48,000 first allogeneic transplants between 1998 and 2007. And this is what they looked at, whether the occurrence of graft versus host disease with different severities, whether acute or chronic, was able to reduce the risk of disease relapse or progression. Obviously, CML is the poster child for the GVL effect, so that if you have graft versus host disease, then your risk of treatment failure decreases. So there does therefore seem to be an effect. It may not be as significant as, say, for example, as you can see over here, but certainly in patients with chronic limited graft versus host disease and even extensive graft versus host disease, the hazard ratios do come down. So there does appear in this sort of registry data to suggest that there is a correlation between the occurrence of graft versus host disease and reduced treatment failure. So that argues for a graft versus MDS effect. So who is your best donor? This was a study done by the Cibmtr in terms of a match-related donor, an 8 out of 8 MUD and a 7 out of 8 MUD. So there is no doubt a superior outcome with a matched-related donor transplant. The next best is your 8 out of 8 MUD, and there wasn't much of a difference between the match-related donors and the 8 out of 8 MUDs. And those two were significantly better than a 7 out of 8 MUD. So that brings us, therefore, if you don't have a full matched related donor or an 8 out of 8 MUD, how are you with haploidentical transplants? Obviously, the Chinese lead the field. This was a Chinese registry analysis of outcomes of 454 MDS patients who underwent a transplant from either a haploidentical source or a matched sibling source. So they were almost 50-50. But the haploidenticals were divided into whether they were 3 out of 6 or 4 to 5 out of 6. What was slightly different, though, is the conditioning regimen that they used. These weren't haploidentical transplants with the post-transplant cyclophosphamide platform. They used a slightly different conditioning regimen, and they used high doses of rabbit ATG for in vivo T-cell depletion. So they used cytarabine, busulfan, cyclophosphamide, simustine, followed by rabbit ATG, 7.5 mg per kilogram. Actually, no, 10 milligrams per kilogram. I may make a mistake because they gave it over 4 days. And the matched sibling donors got hydroxycarbamide and lower dose of cytarabine. In these patients, as you can see again, the best outcomes for overall survival were with an matched identical sibling, followed by a 4 to 5 out of 6 haploidentical. The 50% haploidentical transplants did worst well, and these were the outcomes. So non-relapse mortality was significantly higher in the 50% matched haplos, and it was least in the matched sibling donor setting. The relapse-free survival was best in the patients who had a sibling transplant, but the conclusion was that in the absence of an identical sibling, a 4 to 5 out of 6 match haplodonor was a reasonable option. What about post-transplant cyclophosphamide? This was from Dr. Garcia's colleagues, the transplanters at MD Anderson, where they looked at haplotransplants for older patients with AML or MDS. So they had 25 patients with AML, 10 patients with MDS, and 8 patients with MDS/AML. And these were their outcomes. The 2-year overall survival in the setting was 42%, progression-free survival 42%, and the best PFS was seen in patients with intermediate or good risk cytogenetics in first or second remission. But as you can see, an important point that came out over here was donor age. So the outcomes were much better with a donor age of less than 40, so a younger donor, and good or intermediate risk cytogenetics. So this is haplos in the MDS setting. The colleagues at WashU with Rizwan Romi, John DePercio, Michael Slade, they did a similar analysis in their patients. They looked at 112 patients. Most of these were AML, 95 patients were AML and 17 with MDS. And here they found that obviously the younger patients did better. And if they were older than 65 with the post-transplant cyclophosphamide haplo, they didn't have that good an outcome with a significantly higher relapse or near significantly high relapse. And when they compared the MUDs with the haplos, they had a similar outcome. But the haplos had a trend towards perhaps being less toxic, but that wasn't significant. So it appears that among patients over the age of 65, the MUDs, the donor type didn't affect overall survival. Haploidentical donors in older patients are an option, but again, it comes down to a careful selection of patients looking for comorbidities and a low comorbidity index. So in terms of factors that affect engraftment, there are host factors such as disease effects, the conditioning regimens that they use, immunosuppression, and what sort of post-transplant therapy we might use, including withdrawal of immune suppression or whether we consider using azacitidine. And then there's graft sources and the stem cell dose, the T cell dose, for example. The stroma does matter. And we know from experience that the patients who, for example, have MDS with fibrosis or the MDS MPN, they have engraftment problems, and perhaps the myelofibrosis patients, those are probably the worst patients to transplant because of engraftment issues. So when we're looking at conditioning regimen, we're looking at either the myeloablative conditioning or the reduced intensity or the non-myeloablative. And perhaps the non-myeloablative regimens of maybe are less of a vogue, certainly with us. We don't use it as much. We use the reduced intensity or the reduced toxicity regimen. So there are perhaps 2 important studies here. There's the BMT CTN 0901, where they had patients aged 18 to 65 who had low comorbidity scores. They were in remission with less than 5% blast, and they were randomly assigned to receive either a myeloablative regimen or a RIC regimen, followed by a transplant from an HLA-matched related or unrelated donor. For the MDS patients, they had 54 patients. So they had 27 who had a myeloablative transplant and 27 who had a RIC transplant. Now, this study was stopped early because of, in the AML group, the better survival with the myeloablative transplant conditioning and the very high relapse rate in patients who had the RIC. However, as you can see on the right over here, that didn't seem to matter as much with the MDS patients. They seem to have a similar survival whether you had a MAC or a RIC transplant. Then came the Rickmax study, or about the same time. The Rickmax study was the Ebmt study looking mainly at MDS patients. They looked at 129 patients from 18 centers. Patients were randomly assigned in a 1-to-1 ratio. And this is what they found. The patients who had a RIC transplant seemed to have a slightly better overall survival than patients who had a myeloablative conditioning. And in a multivariate analysis, if you can have a look over here, for the overall survival, there was a significant improvement in survival in patients who had the RIC regimen. So whereas the previous recommendations were that they should get a myeloablative regimen, what this study seemed to show is that you don't need to subject patients with MDS to a myeloablative regimen. And they can have similar, if not better, survival outcomes with a reduced intensity transplant. So who benefits? So this was an earlier study done in blood from over a decade ago that looked at timing of transplant. And when it comes to the question of timing, this is probably what's most helpful to us. In patients, essentially, who are low risk, if you transplant them at progression, then they live longer than if you transplant them immediately. So the message is you can delay transplant in low risk patients. And there's a similar trend in patients who, as you become higher risk, then essentially you want to transplant them earlier. So the high risk patients with an immediate transplant, they live longer than if you transplant them at AML progression. Okay. And there was a similar study looking at analysis in JC of 2013 for patients with de novo MDS, age 60 to 70. And essentially what this analysis showed that in the upper curve is for the low risk MDS patients and the lower curve is for the high risk patients. So you can see over here in the low risk patients, a non-transplant strategy is better than doing a RIC. And in the high risk patients, you're better off doing a RIC transplant, especially with longer follow-up. And what this essentially shows is that the curves cross over here. Earlier on, it doesn't look like they survive. There's a fall off, but you are able to save patients more later on. This is the MDS algorithm for of the NCCN. So if the patient is high risk and they're a transplant candidate, either take them straight to a transplant or AZA followed by transplant. If they're not a transplant candidate, then azacitidine is or a clinical trial. So in summary, especially the high risk patients or even the intermediate risk patients, especially if they're younger and they have a donor, consider referring them early. There are now more donor options with haploidentical transplant and post-transplant cyclophosphamide. A RIC transplant is probably sufficient. And more important than age is an assessment of their poor performance status and comorbidities. And with that, I will end. Thank you very much.
Thank you, Dr. Syed, Ahmed. Nice and clear. And we would leave the questions to the end. Maybe for the audience, if you have questions to any of the speakers, put them in the Q&A. Our next speaker is Dr. Abdullah Alsuwaidan, who will address some diagnostic issues, especially when it comes to the NGS. He is currently a consultant, molecular genetics and hematopathologist at King Faisal, Riyadh. He has been extensively trained in the field of immunology with an immunology fellowship, hematopathology with a fellowship, and then specifically molecular genetics pathology fellowship. He would, in the next 15 minutes or so, he would teach us some how to read Chinese, the report of the NGS in Myeloid panel. Thank you, Dr. Abdullah. The mic is yours.
Yeah, thank you so much for having me. I'm very happy to be here, and I would like to thank the organizing committee for inviting me to this talk.
Dr. Abdullah, if you want to share the slides, I think okay, it's coming back. Your screen is coming back, but not the slides. Oh, now the slides are there. Thank you.
And are you seeing the presenter view or?
And now we can see them, yeah. Yeah, you can go ahead.
Let's see. Are you seeing my slides or the presenter view?
No, we're seeing the slides, but they disappear and they come back again. Maybe try to advance it. Yeah, now we can see them. Yeah, you can go ahead. They disappeared.
Yeah, I don't know what's the issue.
Now they're on. Are they on display mode now or on?
Sorry, I'll try again.
That must be a Mac.
Yeah, it's my Mac.
We can see them. Try to.
Can you see my slide now?
Yeah, yeah.
Okay. So thank you so much for having me today. It's a pleasure to be here and to be with you guys. And MDS is an interesting topic. I will try to present like a brief overview about reading NGS. And I would like to start by having how we approach these cases, how we approach MDS cases. So for me, I always think of it as a multi-approach. So it's not just the morphology, but also the clinical history, the immunophenotypic finding, the karyotype, everything together, putting together to reach to the prior diagnosis. So to have the proper diagnosis is not just having the molecular finding, not just the karyotype, but having all of the findings together. And molecular become an important thing these days, since we are starting to know more and more about the molecular genetics of MDS. Now, when we discuss MDS and molecular testing, molecular can be used to diagnose diseases and for monitoring, and can be used for classification, prognosis, for MRD. So it's not just being used as the diagnostic, but also has several significant roles. And just a brief overview about the NGS. NGS is a technology that's known as massive parallel sequencing. So basically, you are sequencing the DNA fragments multiple times. So sequencing them multiple times, and this will reduce the chance of error compared to single sequencing. And basically, we're preparing the library by fragmenting the DNA into small fragments, then sequencing. Then after the wet lab, there is the bioinformatics lab where we analyze every read. And as you can see here in this example, we have the forward and reverse reads. So you can see how this KRAS mutation has been found several times, and you can see the name of the mutation. So MDS is a heterogeneous group. It's not one disease. This is why we call it NGS syndromes, or excuse me, multiple myelodysplastic syndromes, because it's not one disease, but it's multiple disease, and all of them characterized by bone marrow failure in some way, abnormality in cell growth, proliferation, and leading to ineffective hematopoiesis. And at the end, as you know, it can lead to cytopenias. There is variable risk for progression to AML. And one of the categories for AML is AML with myelodysplastic related changes. And MDS is usually a disease of elderly. As you know, to diagnose MDS, you need cytopenias. So cytopenias is essential. However, cytopenias alone cannot give you a diagnosis. So there are lots of people who have cytopenia without MDS. So cytopenia is only one step. If we depend only on cytopenia, then we don't need bone marrow, we don't need molecular for diagnosis. With cytopenia, you need at least one of these three, either dysplasia, increased blast, or MDS-related cytogenetics abnormality. In terms of mutational analysis for MDS, there are several pathways and mechanisms to get a mutation, including ribosomal protein abnormalities, epigenetic regulators mutations, DNA, RNA splicing, transcription factors, tyrosine kinase signaling, and tumor suppressor gene. And as you can see here, the frequency of these mutations, so F3B1 is one of the commonest mutations, followed by TIT2, SRS, F2, and ASXL1, and etc. And these mutations that highlighted in red are associated just mutation to diagnose MDS. We see in other diseases, like if you look at the right or clonal hematopoiesis of indeterminate potential have similar mutation to the one that we see in MDS. And clonal hematopoiesis of indeterminate potential is usually seen in elderly people. So as we get older, we accumulate several of these mutations with time. CHIP is not totally benign, so it's associated with increased mortality and associated with cardiovascular diseases, and also it's considered in some way a pre-MDS stage. So when we look at this soup of alphabets, so we can see we have the CHIP, we have the cytopenia of indeterminate of unknown significant, we have idiopathic dysplasia of unknown significant, and we have the clonal cytopenia of unknown significant. All of these, they share some factors, but they are not the same. So when we talk about cytopenia, can be idiopathic if you don't find any clone. So clonal will be negative. When we say clonal cytopenia, that means there is a mutation, it's a clonal, but we don't have dysplasia yet. So there is clonality and there is cytopenia. On the other hand, CHIP will have the clonality, but there is not enough cytopenia, or did not meet the criteria for cytopenia. MDS, on the other hand, has both dysplasia and cytopenia. So this is very critical when you try to analyze the mutation. It's not every mutation is MDS. You can see it even in CHIP or in clonal cytopenia of undetermined significant. And cases of MDS arise from previous or pre-existing. So basically, we think about myeloid neoplasm as a spectrum, starting with CHIP, followed by acquiring several mutations that cause MDS, and some of these patients will progress to AML. Very few patients with CHIP will progress to MDS, and very few patients with MDS will progress to AML. And we have some cases that can start with de novo AML without prior MDS. And as you can see, the survival is different. So as the patients accumulate more mutations, their survival will become worse. NGS can help. So up to 80 to 90, depends on which paper you read, you can find mutation, and you can detect mutation up to 90% of MDS. Mutations can be useful in diagnosis, in prognostic, and also can provide some predictive for targeted therapy. NGS or mutation has limited value in confirming neoplastic clonality. So you will know this is a clonal process, but does not mean it's a neoplastic. As you have seen, there are some CHIP and clonal cytopenia that are not neoplastic. And MDS type mutation can be seen in CHIP, and it's increasing with age. So in terms of diagnosis, so let's take the significance of NGS in diagnosis. Accurate diagnosis is very, very critical in MDS. You don't want a patient to get a wrong diagnosis, false diagnosis of MDS. It will cause a lot of anxiety to the patient, and it will put a burden on the healthcare system if you keep trying following up this patient, doing bone marrow biopsies, treating them, and they don't have MDS to start with. So accurate diagnosis, you don't want false positive, and they don't want to miss these cases. So you don't want false negative. Accurate diagnosis is very important, and there is no mutation that's pathognomonic, no diagnostic mutation that this mutation means MDS. That does not exist. But on the other hand, there are several genes, as I mentioned here, all of these genes, and the one that highlighted in purple, these 7 genes, these are the most important genes in MDS. They can discriminate MDS from others with accuracy of 83%, as shown in the last ASH meeting, which was presented. And these genes considered the most important genes in terms of diagnosis for MDS. One of the advantages of NGS is the negative predictive value. So if we say that most cases of MDS has a mutation, 70 to 90% of them has a mutation, then if you get a negative result in the NGS, you can feel very, very much comfortable that most likely it is not MDS, especially if the morphology is not supporting, then NGS may help in these cases. Again, mutation alone do not establish diagnosis of MDS. Prognostic value, you can see S3B1 is associated with good prognosis. On the other hand, the listed genes here in red and in orange, all of them is associated with worse prognosis. In terms of predictive value, there are some, but still NGS and MDS is not, it will not, most of the time it will not change therapy. Unless you find, let's say, FLT3 or TP53 or NDM1 that associated more the Aml type mutation, or if you find IDH1, IDH2, then maybe it will change your therapy, but in most cases, NGS will do little to influence the treatment regimen. So it has more value in terms of understanding the biology of the MDS and in terms of diagnosis and prognosis. These are some mutations that's seen in MDS, MBM. Some caveat about interpreting NGS results. First, you need to think about the panel design. It's very critical to have a well-designed panel and validated panel. It's very important to know what genes included and how these genes are covered, is it fully coverage or partial, what's the sensitivity, specificity, limit of detection for this panel, and all of the test limitation. We usually mention this in the report, like all of the limitations, but you need to know and pay attention to these to know exactly what's the limitation of your panel. Quality of the sample is very critical. So if you give us a good sample, then most likely we will get a good result. On the other hand, bad sample is, you can get inadequate results. It's important to know if your panel cannot discriminate between somatic and germline mutation. Variant allelic frequency is very important. So if you find very high allelic frequency, then it's associated with more real mutation. On the other hand, if variant allelic frequency is low, less than 20%, then this could represent a CHIP mutation. Variance classification also is very critical. So you need to get to know that this mutation is pathogenic, not just mutation, because mutation can be also variant unknown significant or benign. Single mutation versus multiple mutation, and there are several studies that shows if you have multiple mutation, then the chance of having MDS is more than if you have only single mutation. At our institution, we have the Myeloid Ngs Panel. This is just one slide brief overview of this panel. It has a good comprehensive panel with 40 DNA genes, 29 fusion genes. Fusion genes play more important in AML cases. It's amplicon-based sequencing. It can detect SNV, NDEL, and fusions, and with lower limit of detection, around 5% allelic frequency. I have a few cases that shows how NGS impact, and I hope I can go them. Just if my time is up, please stop me at any time.
You have 1.5 minutes, Dr.
Okay, then just 1 minute. Then we can take just this first case. This is a 63-year-old male with edema, fatigue, anemia, and splenomegaly. This is the morphology, as you can see here. This patient has leukocytosis, and there are some changes, anemia and others. The aspirate smear was very limited. Biopsy, there's no evidence of dysplasia. It's just, as you can see in this morphology, there's some erythroids and myeloid elements. Megakaryocytes are within normal. Fish shows 20 Q deletion and 5 deletions, so monosomy 5. When we did the NGS, we found all of this mutation. We found IDH1, SRS2, CBL, and KRAS. And having more than one mutation will make MDS more likely. So that's why one thing. The other thing is KRAS and SRS2, both of them are associated with worse prognosis. So we know now this patient is not just having MDS, but also at risk of transforming to AML soon. So basically, we know based on that this patient has MDS. I can skip the rest and go to summary of my presentation. So MDS is a heterogeneous disease. Morphology is still the gold standard, but there is limitation in terms of morphology. NGS is a great technology. It can help in diagnosis and prognosis. Similar to morphology, NGS also has limitation, and it depends on the quality of the sample. Maybe we are using NGS and AML more, but with time, NGS will become standard of care for all MDS patients. And it's not just about providing therapy or targeted therapy, but it will help us understand the biology of MDS and will help us classify our patient and provide them with diagnosis, early intervention, and better surveillance. And thank you so much.
Thank you, Dr. Abdullah. Well articulated and explained. Now we go with the questions. Again, for the audience, you have time to ask questions, so please put them in the Q&A. Maybe starting with the question, I think this is to Dr. Manero. How effective of venetoclax combination with azacitidine in the splicing factor 3B1 mutant MDS who failed hypomethylating agents?
There is no, thank you very much for a very important question. There is no evidence that this kind of mutations makes the venetoclax more sensitive in MDS.
Oh. And so I mean, you would not recommend then that combination?
It will not be against or in favor. It's just that there is no increased sensitivity. The mutations that make the disease very sensitive are actually IDH mutations, IDH2, IDH1, that again, like in AML, you can see in MDS, they make these cells very sensitive to venetoclax. And then in contrast, if you are P53 mutated, they have poor response to venetoclax. So it's very similar to the AML.
The next question is addressed to Dr. Syed Osman. For the patients with MDS with high blast count, not making AML, but high blast count, do you debulk before transplant?
Now, the previous ELN recommendation used to be that it is recommended for patients who've got more than 10% blasts to get some sort of debulking before a transplant. But I think it may be a bit more complex than that. Now, supposing if you have a patient who has a very poor risk cytogenetics, or say a TP53, then you have to balance the risk of giving them some chemotherapy that they probably won't respond to, and the toxicity that will cause that may compromise your outcome. That's one thing. So in a patient like that, what we sometimes do is do a sequential transplant with with cytoreductive chemotherapy, like a Flamza-like approach, followed by reduced intensity conditioning, and then the transplant. The other factor is that if you do have close to 20% blasts, and if you're going to do a RIC transplant, then that might not suffice. So it's a balance of whether you go straight to whether you do a transplant, in which case you're going to have to do a myeloablative one. So I think it will depend. I think the answer to that is it's always a challenge, but it will depend on the patient and the kind of conditioning that you're going to do, and the risk of attrition as a result of giving either hypomethylating agents or chemotherapy. There are situations where the patient gets more sick and gets a fungal infection because of the chemotherapy that you've given to reduce the blast count as 14% or something. And then you actually can't do the transplant, or it compromises the outcome of the transplant, or it increases the risk of TRM. So I don't have an easy answer, but it has to be customized to the patient and what they can tolerate. So I would say if it's somebody who is young and doesn't have comorbidities and they have close to 20% blasts, then yes, those patients I would debulk with some chemotherapy, like an AML-like chemotherapy, and then take them to a transplant. If it's somebody who is less fit, then I would probably give them a hypomethylating agent. But in other patients, we have low disease bulk, like something closer to 10%, then in those patients, I might consider taking them straight to a transplant. I don't know if that answers the questions, but it's customized.
It just shows that the lack of convincing data on either way makes it kind of difficult to give like a one answer. So the best answer is like, it depends, right?
Yeah, it has to be customized to the patient and your type of transplant.
Thank you. The next is to Dr. Abdullah, Alsuwaidan. So are all suspected MDS tested for that extensive NGS panel?
Yes, thank you very much. This is a great question. And right now, our selection criteria is to have a cytopenia. So you need to have unexplained persistent cytopenia and hint of dysplasia. So you don't need the dysplasia to be 10% or more. So any even mild dysplasia, we will accept these cases for the NGS. In some places, they do it just for cases with cytopenia. But definitely, if there is no cytopenia, then don't bother to do NGS in these cases, because cytopenia is an essential in terms of diagnosis for MDS, and always correlate with the morphology. So if the morphology shows a hint of dysplasia, then please go ahead and do the NGS.
I mean, related to this question, would you use the VAF as a response assessment?
That's also a great question, and there are, all of these things. There are no consensus in the community, so you will hear different opinion and different publication. But at least what I believe is using variant allele frequency can be very helpful in these patients. And we need to differentiate between using VAF to follow up these patients, and this is totally different from minimum residual disease. So NGS, and most of the time, it's not designed for minimum residual disease. But we have seen several cases where after therapy, they repeat the NGS and they found the high risk clone is decreasing. So let's say the patient has TP53 mutation or KRAS mutation or FLT3 NPM1. Then after therapy, you find that this clone is reducing. It's like, you know, this patient risk to progression to leukemia is reduced because of your therapy. Again, this is not MRD. This is just using it to evaluate how patient is responding. On the other hand, after your therapy, the CHIP mutation will stay the same because these are clonal hematopoiesis. It's not related to the NDS. I hope this answered the question.
Thank you. The next question is to Prof. Manero. So again, to the high-risk MDS for patients over 65 years old. So what is the your best therapy outside the clinical trial for those patients with high-risk MDS over the age of 65 now and probably after the next ASH?
So I will respond like Dr. Ahmed. So you have to really make it very personalized. That's the message of this symposium today. So let me give you a couple of situations. So 65-year-old gentleman with diploid cytogenetics NPM1 mutation. Again, this is 1% of cases. These patients can be cured with a high-dose RAC-based program followed by an allogeneic stem cell transplant. So that's one extreme. In the other hand, 65-year-old person with very complex therapy-related MDS, very complex karyotype, P53 mutation with a very high BAF, that patient is going to do very poorly with any form of chemotherapy. The standard of care will be a hypomethylating agent. So basically, the standard of care will be a hypomethylating agent. You need to look for the patients that may benefit from different therapies. So good mutations, good cytogenetics. Maybe if you think that they could tolerate some intensive therapy, that could be, and intensive is not like AML therapy, you know, a little bit more than hypomethylating agent. So as Dr. Syed was saying earlier, it's all about making it personal based on comorbidities, the type of donor, the type of cytogenetic, and the type of molecular. So with that, then you can make a plan. You know, this is very tricky question because 65 is kind of the limit for chemo transplant. If you tell me the patient is 50, you know the route you're gonna go. If the patient is over 70, we know. But this group of 60, 65 are sometimes complex because not all of them are candidates for transplant. None of them may be candidate actually for more intensive type of therapy. So it all depends on chromosomes and the molecular comorbidities and do they have a donor.
Thank you. The next question is to Dr. Syed Ahmed. You presented two studies for the myeloablative versus RIC as a conditioning regimen for the MDS patients. The second study showed in the multivariable logistic regression, or I guess here Cox model, showed a hazard ratio of 0.4, 60% reduction in mortality, which is huge for what you would expect as the impact of conditioning regimen. So, I mean, do you think it's true, or was it that the myeloablative regimens that they used killed more than expected, rather than the RIC saved more than expected? You're on mute, Dr. Syed Ahmed.
I'm not sure. I think it's to do with how they, to a certain extent, how they did after they relapsed, if I recall correctly, because the relapse incidence was obviously higher with MAC, but that wasn't. It usually comes down, as in most of these EBMT, it usually comes down to the TRM, but I'm not sure. I'm not sure. As to why that, because the question the person that asked the question was saying, why was the hazard ratio? I'm actually bringing it up again. Okay, you said, why was the hazard ratio for so the hazard ratio for the RIC for overall survival was 0.4. Yes, so there was a significant reduction in risk of death with a RIC. And there was also a non-significant reduction in non-relapse mortality with the RIC transplant. The risk of sorry, can I ask you to repeat that question again? If you don't mind,
that hazard ratio is too good to be true for a simple change in conditioning regimen. If the signal was that much of a different, you would have seen that signal in the first study that you presented.
Okay, fine. Sorry. Okay. Now, just to say, the first study was AML and MDS, right? And the MDS was a smaller cohort, like 27 patients, as I said. And actually, if you look at that first study, the curves, okay, were close. Okay, there wasn't a difference between RIC and MAC. The second study, the Rickmax study, was a purely MDS study, so the numbers were larger. Okay, so that might have an impact. And what they postulated for the Ebmt is it's probably, again, because of a lower result of mortality after relapse. And they did break that down. They said fewer patients in the RIC arm died after a relapse in the RIC-MAC group. So what it suggests is that the patients who died after MAC, they had very resistant disease, because if they had disease after a myeloablative transplant, then it was probably a reflection of the biology of the disease that they had. But they did say it's probably because of lower mortality after relapse in the Rickmax study. So but the main factor why you have a difference between the BMT 0901 and the Ebmt study is probably the sample size.
Oh, makes sense.
Probably.
Thank you. The next question is to Dr. Abdullah, but it's that I noticed that the number of participants is 1,800. And by the all Omani standards, like this is a very well really attended meeting. So we go to Dr. Abdullah's question, and now I cannot find it, but if it is, the question is about genotype-phenotype correlation. Does the NGS panel, can it correlate with the risk categories of the MDS?
Yeah, thank you so much. This is a good question, and there is no consensus on this one. So there is a different publication about using one mutation to classify as high risk or low risk. There is no consensus. The only one that I know is SF3B1 is associated with good prognosis, that there is like a agreement on that. The rest of the mutation, TB53 is also considered one of the aggressive mutation, and especially if you have biallelic mutation. So if you have biallelic mutation in TB53 or biallelic mutation in other genes, it's like knocking both copy of alleles, then this is usually associated with aggressive. But again, there is no consensus about classifying MDS using mutation. You will find different publication, and still very early to decide.
Oh, thank you. Now, the next question is to Dr. Manero. What do you think the role of luspatercept in the management of low-risk MDS?
Yes, this is a good question also. This is evolving. Right now, this is for second line after ESA failure for low-risk disease. There is a very important study called COMMANDS that is now randomizing in the frontline low risk, so it will be luspatercept versus ESA. If that study is positive, then this will be the next intervention for low risk MDS. So this drug is in evolution. We need to learn more about this. But right now, second line after ESA failure, that's where we stand.
Thank you. Now, the next question is again to Dr. Abdullah. What is the role of NGS in the diagnosis of pediatric hypoplastic MDS?
I should say that I'm not the expert in the pediatric hypoplastic MDS, so I don't know, but most of the mutational panel include genes for germline mutation. Usually pediatric age enrich for germline mutation, so I expect that NGS will help to find if there is any mutation in germline. But again, I'm not the expert, and I don't have a good answer for this.
Thank you. So the next question is to Dr. Syed Ahmed. In the region, I mean, you presented the King Faisal, I don't know, or the Saudi data of only 5% of your transplants are for MDS. Isn't this underrepresentation of the MDS? Like, do we wait for those patients to progress and we transplant them as the AML, or you think this is a fair representation of patients with MDS?
I think, and I'm sure Dr. Garcia would agree, that most of the patients that they deal with in the US, especially if you compare the West, most of these patients are above the age of 65. You know, our transplant numbers are skewed to younger patients because of the younger population that we deal with. So that's probably one of the reasons why you have relatively lower numbers of MDS transplants. Then there are obviously you know, alternative donor issues, especially in the old cohort that we were dealing with. You had fewer haplos and MUDs, but now that's emerging more as an entity. Now we have, you know, more access to MUDs, certainly in Saudi Arabia, and we have the haploidentical transplants. So I would expect numbers to increase, but again, it's an age-related factor.
Thank you. The next question is, and we still have a few more minutes, to Dr. Manero. This is about the TIM3 antagonist, and specifically, actually in AML rather than in MDS. And the question is, kind of rephrased it. Does it make sense to use the TIM3 inhibitor after induction in patients with AML to get rid of the MRD?
This is very nice question. Actually, this is beautiful question. This has been investigated to use this kind of modality to like control disease and control MRD negativity, etc. Particularly because this drug doesn't seem to have a lot of toxicity in terms of the immunological toxicities with other checkpoints. So that's very important. The same thing with the Macro, maybe pevonidostat as well. That's a very important question. Unfortunately, Dr. Murtadha, I need to go to hospital in a minute, but one point that I would like to make, if you allow me, is that these combinations most likely are going to be triplets because they are easy to tolerate. So this TIM3, the sabatolimab, macrolime, these drugs are not very myelotoxic. So in the future, we see doublets, triplets, maybe post-transplant. We have not discussed this, but this is also very critical, you know, to think about what we do with our patients after transplant with MDS because of the rate of relapse. And I think these new modalities are really going to help us control the disease, similar to what the multiple myeloma doctors have done now for a long period of time. So this is very exciting, but it all pivots around the mutation data. You know, we make decisions, as Dr. Syed was saying, around transplant based on the mutations and post-transplant as well. It's becoming really critical.
Thank you.
I want to thank you so much for the opportunity, if you allow me.
Thank you very much for attendance and very enlightful lecture.
Great honor. Hope to see you soon.
Thank you.
Thank you.
So we take one more question for Dr. Abdullah and then Dr. Syed, and then we finish. So for Dr. Abdullah, like more of a basic NGS terminology. What is meant by depth and coverage? Are they the same thing, or in NGS overall? Yeah.
Great. Yeah. This is a good question, and coverage sometimes confusing. So we have two terminology. We have extensive coverage and we have depth of coverage. So the extensive coverage is how covers the gene. So as you know, genes are very large. Some of them have 20, 30, 40 exons and intronic regions. So we would like to know if the gene is entirely covered in this panel or only small part of the gene's hotspot or important domains that's covered on the sequence. So basically, we would like to know if it's full coverage or partial coverage of the gene. That's the extensive coverage. On the other hand, the depth of coverage is how many times we sequence the variants. So if we have one mutation, how many reads we have for each variant. This is what we call depth of coverage. And in cancer world, we like depth of coverage to be around 2,000 preferably. We can accept up to 1,500. But lower than that, you start to feel that it's not enough for diagnosis.
Yeah. And for a limited panel, it is easy to do that much of depth, but not for whole genome, right?
Exactly. So I'm talking about targeted panel, similar to the one that I present. Then, yeah, for whole genome or whole exome sequencing, definitely you cannot reach that. So sometimes you go by 50 or less reads. Yeah.
Thank you. The next question is to Dr. Syed Ahmed. Now, about the Graft versus MDS effect. Do you think it is there? I know you presented one study, and is it more or less than the ALL, patients with ALL?
I'm not sure how easy it is to quantify it, other than the data I showed. There does seem to be, and obviously there's the work from the Germans, like Platzbecker and colleagues, when they gave the patients who had post-transplant relapses and the DLI and the azacitidine, that seems to elicit an immunological effect in improving chimerism and maintaining remission. So there probably is a degree of graft versus MDS there. Maybe the hypomethylating agent modifies it somewhat, but we know from the MD Anderson phase 3 study that the maintenance and high risk doesn't really help, so we need more data for that. But there seems to be.
Thank you very much, Dr. Syed Ahmed. And in the last maybe 20 seconds, I'll make some kind of announcement. So this session is fully recorded, and you can watch it at your leisure later on if you wanted to learn more about challenges in MDS. There is annual Saudi Hematology Congress for 2021, which will take place virtually. It would cover about, it would be over 7 days. Day 1 would be the Saudi Hematology Research Day. Day 2 and 3, critical reviews in hematological malignancies. Day 4 and 5, innovation in hematology. And day 6 and 7, benign hematology and transfusion medicine. It would be from 4th to 10th of March next month in 2021. I guess in Riyadh or any other place as you could attend virtual. So try to make it. It would be very educational from the agenda just listed. So with that, I would like to thank the speakers. Very nice 3 talks. A very nice discussion. The session is kind of well organized. I would like to thank the audience, the 1,000, now 700. It was just 1,800. The 1,700 attendees who participated with their attendance and the questions. And I would like to thank the organizers for the, like Dr. Firas and the team for the coordination and the and planning of this session. And the session is now concluded. Thank you very much.
Yeah, thank you so much.
Thank you very much. Dr. Firas, Dr. Murtadha. Thank you.
Thank you. My pleasure.
Salam.
Are we still live? Or?